Hello, my name is Soheila Rostami. I'm an Oculofacial Plastic Surgeon and the founder of Sanctuary Cosmetic Center. Uh, Today, we're going to talk about the surgeries we did together, and hopefully, we'll be able to use the photos of the patients that we did surgery on, so we can discuss it later on the photos. But let's just start with the first case. Um, the first case that we did was upper eyelid blepharoplasty with fat repositioning on the left side with bilateral lacrimal repositioning and also right lower eyelid fat removal. So it's so strange that
It
we
was
have
strange.
kind of like partially this eye is different than the other eye. And to give a little background to it, this patient in particular had thyroid disorder and developed thyroid orbitopathy and or thyroid eye disease. And the left eye developed exophthalmos, and they had to do orbital decompression. And secondary to orbital decompression, the patient developed asymmetry between the two eyes. So that's the reason it's kind of weird how we're doing fat repositioning on one side and then fat removal on the lower eyelid on one side. So to make the eyes a little bit more symmetrical. Hopefully she would allow us to show those photos, then it would be more appropriate to explain on the photos why we decided to do those kind of surgeries. Now, talking about lacrimal gland repositioning, a lot of times in some patients, you see some fullness in the lateral part of the eyelid. Some people make a mistake that they think this is fat. It's actually not. That's where the lacrimal gland sits. And when we have lacrimal gland prolapse, this is how it appears. So you have to be very careful assessing the upper eyelid and making sure that by touching and by also having them looking down, lifting the eyelid, can you see the lacrimal gland? And if that's the case, that means that they have lacrimal gland prolapse. So for making the eyelid look nicer, more cosmetically pleasing, the lacrimal gland needs to be repositioned back in its socket. So right underneath the orbital rim, it should be nicely placed in there. So how do we do that? You saw it.
So
Yeah.
we first make a skin incision, and then we dissect down through the orbital septum, and then we are able to immediately identify the nasal fat pad and then the central fat pad lateral to that, and then lateral to that is the lacrimal gland, and it definitely has a different appearance and consistency compared to fat. It is kind of pinkish, kind of looks like a brain.
Yeah, lobulated. Yes, exactly.
Yeah. And then when we went through the orbital septum on the lateral aspect, we were able to immediately identify the lacrimal gland and see that it was clearly prolapsed. So you took stitches, you used a 6-O-proline, you hooked the tail of the lacrimal gland, and then you fixated it to the periosteum.
Periorbita. In the orbit, we call it periorbita. So you fixate it inside the periorbita, inside the orbit to the periorbita, and secure it down. And the reason I like the 6-O-proline is a permanent suture, so you know that it's gonna stay in place unless the suture comes off. Because sometimes scarring doesn't really happen between the capsule of the lacrimal gland and the periorbita. So because the two are, they're already right next to each other, if they were supposed to form a scar to each other, they would form. So that's why sometimes I think that just putting a dissolvable suture may not really help us to keep the lacrimal gland in position. So, and how did we check? We saw that we cannot see the lacrimal gland coming forward. So we actually were able to confirm that it's in good position. Am I right? Yeah. So there was no more fullness in that area. Okay, so that was one of the things. Then on the left side, since we had what we call superior sulcus deformity, we needed to do fat repositioning. Can you explain that, how we did that? How did we accomplish that?
So for a superior sulcus deformity or hollowing, again, we make a skin incision and then we dissect down through the orbital septum. You wanted to be very careful, so you were very medial when entering the orbital septum, and you dissected out the central and the medial fat pad, and basically you make a small flap and fixate it, redrape it and fixate it so that it looks more cosmetically pleasing.
And the other reason I wanted to have the fat there, because of the surgery they have done, the septum kind of attached itself to levator muscle. So we wanted to separate the septum from the levator muscle or the levator aponeurosis. So I wanted the fat to be right in between the two and gives us a nice separation. And then that way the septum will not touch it or attach itself to the levator muscle. And this one gives us some security that first of all, we have some body to give us the superior sulcus deformity go away, and then secure that with the 6-0 vicryl to the orbicularis and a little bit of the levator aponeurosis right there. Okay, so that's how we got the fat repositioning, and then we close both with 6-0 proline in a running fashion. So that's how we achieved our upper eyelid. Now, lower eyelid, I do transconj, and it's a very easy procedure. I don't think it's that difficult, lower bleph, when you do transconj to remove the fat. So it's a very fine line between the two. If you take too much, they will have some defect, and you have to give them fillers or fat. And fat repositioning, if it's a small amount of fat, really doesn't give you the ability to be able to reposition it, because let's face it, it's so a small amount of fat. And this lady had that kind of very, and I didn't want to reposition it because it would have made a difference with the other eye. She just wanted to have that little bubble go away. So we just wanted to remove a little bit of the fat. I don't like the open sky technique for the transconj. And the reason is because there is no need. And I truly believe that when you cut through the retractors, that's the way you have to expose all the fat compartments, you decrease the function of the lower eyelids. And I believe that retractors have a very important role. And as they get older, there is a possibility that you decrease the function of the lower eyelid, and they can develop entropy and ectropy. So for that reason, I make small openings, and I've never had any issues. I bring out as much as fat that I believe that is necessary, and I cauterize it and let it retrieve back to the orbit. I've never had issues with that, and that's the way I like it. I don't want to mess up the retractors too much. So that was one of our cases. So do you want to explain the second case?
The second case. Oh, yes. So the second case, we did fat grafting to the face. We harvested fat from the abdomen, and we wanted to focus our facial fat grafting in the kind of under eye area because it was pretty hollow appearing, and also his mid face was also kind of atrophic from aging, and it's also genetic factors as well. So after liposuction, we did manual liposuction to try to decrease the amount of trauma that we have on the fat. And then we purified the fat, and then we filtrated it down to, first we used regular fat, and then we used microfat, and we create that by using a filter to less than less
1
than
millimeter.
2 millimeters
Yes, less
is
than
micro.
2. Yes, so between 1 and 2 is the micro fat.
Micro.
So we passed it through 3 millimeter, 2.4, 1.4, and then 1. So 1 gives us a very nice cellular level fat.
So that's our micro fat. And then we filtered it down even more to nano-fat, which is void of any actual adipocytes. It's mostly mesenchymal stem cells, adipose-derived mesenchymal stem cells. Correct. And the stromovascular fraction of our collection, or of our aspirate that we purified.
There's one step that I think that we should mention. We really care for getting the lidocaine out, because remember, lidocaine is toxic to fat cells. So we clean the lidocaine because that's how we put the tumescent to be able to harvest the fat. So now we have to get rid of the lidocaine. So we wash our fat. Everything is manual. I don't believe in centrifuge. We just let the fat sit. We get the lidocaine off that way. Then we use the system that is called Pure Fat, and
Tulip. I think it's made by Tulip.
No, those are the filters. The little bag that we are able to wash the fat with, and we wash it with saline. It's actually Pure Fat system, and so we put the same amount of if we harvest 30 cc of fat, which we did, we add 30 cc of normal saline, and you wash it twice, and we get the 30 cc out. So this way we know that we're not having any normal saline remaining in the fat. And there's a nice filter. So you should follow the instructions for the pure fat. So you leave it for a minute, you let it sit, and the filter works, and then you pull the fluid out. This way, we know that the fat doesn't have the toxicity of the lidocaine with it when we're injecting into the area. So I like my patients to be sedated because we're not using any lidocaine with our fat, so the pain is there, but at the same time it helps us because it will get the fat to be more viable for the patient. So now and then the nano fat, we pass it through 0.5 filter and a 0.3 filter. So at this point there is no cell. So actually we're using the benefit of the mesenchymal cells, and that stimulates the stem cells come to the surface and help us with the skin quality. So the skin quality and the fat survival as well. Okay, so with mid-face deficiency was taken care of. We didn't inject anywhere else. It was just the mid-face to be able to help with the tear trough and also with the cheek development. Okay, so I think that was an interesting case too. Yeah. Now let's talk about the third one. It's a simple one.
The third case was just a blepharoplasty for dermatochalasis, excess skin of the upper eyelid. So with that, Dr. Rostami did the preoperative markings. She always makes sure to leave at least 10 millimeters of skin behind above the eyelid crease that is kind of created or recreated in the operating room.
And 10 below. So and total of 20.
Yeah. So that's based off of the tarsus of that patient, and it's kind of patient specific or ethno specific. Our patient was white, but she had eyelids that were kind of mongoloid appearing, I believe is the correct term to use. So she had kind of a epicanthal fold, and she also had what we call hooded eyes, where there's excess skin coming over to basically the ciliary margin. Yeah. So.
And not much of a tarsal plate, very small tarsal plate. So for that reason, it wasn't a typical eyelid surgery, not more of a ethnic eyelid surgery, even though we had a white patient. So you have to be very careful. You don't change the epicanthal fold. For cosmetic patients, you really have to discuss that with them. And I knew she doesn't want to change that appearance. So epicanthal folds are very, very important not to be touched, because they really make a scar in that area, unless you've discussed it with the patient and they really want to change it. So that's a different story when you want to change it. So try to stay with the fold and stay with the incision along with that. So then you won't get into trouble of forming any kind of webbing in that area. And that's not a very pleasant, cosmetically pleasing situation. And then I usually don't remove central fat pad, but for those hooded eyelids, I do remove some central fat pad, because it gives them more of a defined lid crease, and they would like it a little bit more. Otherwise, we really didn't change her superior lid crease. We kept it in the way it is. You want to add anything for the ethnic eyelids?
Sure. With my Korean background, I do have I guess a big interest in Asian eyelids. And so there have been a lot of studies done. There's been a lot of cadaveric studies and also, studies on real life patients. But the anatomy of the Asian or northeastern Asian eyelid is distinct from Caucasians. So like we talked about, the tarsus it tends to be shorter. It tends to be about 7 to 8 millimeters versus 10 to 12 in Caucasians. And also the insertion of the orbital septum onto the levator happens to be a lot lower in Asians. And because of that, there is pre-aponeurotic fat that drapes down lower to the eyelid. And with all that fat, it is kind of harder for the muscle to create a clean crease. Yeah. And also the insertion of the levator aponeurosis is multi-lamellated versus a single lamella for Caucasian folk. So that multi-lobulated nature of that aponeurosis also makes it difficult to have a kind of a clean crease. And then on top of that, there's a medial canthal fibrous band that is distinct to the northeastern Asian population, and that is what gives about 70% of that population an epicanthal fold. And basically, the vertical tension on the medial canthus exceeds the lateral tension forces, and so there's too much tension vertically, and so there is basically, it looks like excess skin kind of pooled vertically, but that is also a northeastern Asian trait.
Now, in my hands, I've noticed if you don't do open skin lid crease formation, they don't last as long. And I believe it's because of that fat that is separating the tarsus and septum. So I really believe if you want to do a very good job to create a proper lid crease, and this is what they want cosmetically, you really need to make the incision, and you have to consult them really nicely. Tell them that if you really want to have a very nice formed lid crease, you need to have that incision. And then remove the fat. Remember what I was saying? That central fat pad should be removed a little bit. Not too much. I'm not talking about like really removing it, because you don't want to completely change their appearance and creating a superior sulcus deformity. That's not acceptable either. But just enough to give you a very nice attachment of the tarsus to the skin to the septum. So then you can have a nice form of the superior crease for them. So I've learned that, at least in my hand, that's what I feel. That's how I think that it would be a best way to create the superior crease.
I agree.
Okay, well, thank you.